Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our Conversation with Cancer Experts series, I have one of the leading experts in myelofibrosis who's generously agreed to give us his time to talk about how he treats myelofibrosis in second line. We will talk a little bit about the initial approach as well. So I want to welcome Dr. Prithviraj Bose, professor at Department of Leukemia, MD Anderson Cancer Center, the leading cancer center for a variety of hematological malignancies and obviously all cancer. Welcome, Prithvi.
Thank you, Ravi.
So, Prithvi, just to get started, when you do have a patient with myelofibrosis, what are your goals? What are you trying to achieve?
Ravi, traditionally we've talked about spleen and symptoms, and that's been largely because those were the strengths of ruxolitinib, right? So that was the first drug approved, 2011, and for nearly a decade, that was the only drug. And so spleen and symptoms have, become sort of the cornerstone of what we seek to improve with our drugs. However, now that we have 4 JAK inhibitors approved and non-JAK inhibitors coming, hopefully, the conversation is increasingly moving towards survival, towards disease modification, recognizing that spleen and symptoms are important, but they per se, again, the spleen reduction we do consider a biomarker of efficacy, but there's a lot more to the disease than spleen and symptoms. So a lot of the discussion these days in the field is that we need novel endpoints. Anemia, for example, anemia is almost a hallmark of the disease. Everybody gets it at some point. And so things like transfusion independence, anemia improvement, and of course, surrogates for survival, right? Like there are efforts now to define PFS or EFS in this context, which has never been done before. So I think it's an evolving area, but overall survival is, as always, is the overarching goal, and so I think we are moving in that direction.
So, a couple of questions. So, you mentioned surrogate a couple of times. So, is spleen reduction anemia response a surrogate for survival?
So what we know is that in the context of ruxolitinib, for example, spleen reduction does correlate with survival. And in the context of momelotinib, which was recently approved last year, we know that transfusion independence correlates with survival. So we do have these fairly well-established markers where if you are improving spleen, improving transfusion dependence, then you are improving survival. We do know that. But I think the disconnect is because with the JAK inhibitors, we've not seen that much of an effect on the driver mutation allele burden, on bone marrow fibrosis. So a lot of the discussion is around what do we really need to do to move the needle in the disease in terms of a solid surrogate for overall survival. And I think the field is still searching for those with allele burden reduction, bone marrow fibrosis reduction, cytokine reduction. These are the 3 ones that are mostly talked about in that context.
So, you also use the word disease modifying. Is it what disease modifying is that the reversal of fibrosis, allele level reduction? How do you define disease modification?
So that again is absolutely not well defined in this context, and a very hotly debated subject. We know, just to be clear, that ruxolitinib, for example, does prolong survival. Now the big question has been, how can it do so if it does not improve the allele burden very much, or if it does not improve bone marrow fibrosis very much? So people have questioned its survival benefit, partly because of those facts, where it does not seem to have that much of an anti-clonal effect, right? So the feeling is that ruxolitinib improves survival indirectly through improvements in weight, appetite, energy, well-being, etc. So it's thought to be an indirect effect through anti-inflammatory actions of JAK inhibition. Now, so coming back to what is really disease modification, a lot has been written about this. There is not one uniform definition, but the idea is that something that is strongly tied to survival outcome and is shows target engagement, or perhaps I should better say um, improvement in some biomarker that we know is tied to survival, which applies to all cancers, right? But I think in our field, in this disease, I think allele burden is probably number one in my view. Bone marrow fibrosis is questionable because, in fact, your colleague Steve O had published that bone marrow fibrosis changes did not correlate with any meaningful clinical outcome in the context of ruxolitinib and momelotinib. So that one remains a little controversial. I will say that, and cytokines is another one that is proposed as something that could indicate disease modification, cytokine reduction. We know that correlates with symptom improvement, but that's not the same as saying it improves, that it correlates with survival improvement. So I think this is still a very open topic, but of the candidate biomarkers, beyond spleen and transfusion independence, which I already said have been clearly shown to correlate with survival, I think allele burden reduction may be the best surrogate marker.
Thank you for that. So obviously, we're going to spend the majority of the time talking about how you tackle second line myelofibrosis. But to put it in context, obviously, we need to have a little bit of idea, but on a very broad scale, how do you choose treatment for frontline? And then we'll delve into deeper the second line space.
Yeah, I think, first one has to take a step back and ask oneself, what is the biggest clinical need of the patient? Because I think this is a unique disease where we don't treat, for example, by stage. We treat by clinical need. So is the patient, exhibiting splenomegaly or symptoms? Or are they just anemic? Are they just thrombocytopenic? See, the disease comes in different flavors. So I think when you approach a patient for the first time, you're looking at lower risk and higher risk, as nicely illustrated on this slide. And that only helps you, this is a really important point, that only helps you in determining if they should go to transplant. That risk stratification does not inform our choice of pharmacologic therapy. That is based on, again, the clinical need. So most patients will need a JAK inhibitor. And now we even have one that improves anemia, which is momelotinib. So I think in the front line, I think most patients would get either ruxolitinib or momelotinib. Some would get pacritinib, as shown here. If their platelets are less than 50, I think that is probably the drug with the most data in that space. But I think what can be a bit of a discussion is whether to go with ruxolitinib or momelotinib in somebody who is anemic, because both choices could be correct. I don't think there is one right answer there. In a patient who's not anemic or not significantly anemic, I think ruxolitinib would be most people's frontline choice. And then as we move into second line, of course, it gets extremely nuanced. So the way I like to think about it is, these days we talk about proliferative and cytopenic myelofibrosis as being two sort of clinical phenotypes at two ends of a spectrum. So you have this proliferative patients with the bigger spleen, higher counts, etc., lower JAK2 allele burden. I'm sorry, take that back. Higher blood counts, larger spleens, higher JAK2 allele burden, and generally a more favorable prognosis. Fewer non-driver mutations, less leukemic transformation, better survival. So that's your proliferative subtype. And then you've got the cytopenic subtype, which have lower count, smaller spleen, lower JAK2 allele burden, lots of other mutations, non-driver mutations, more leukemic transformation, and worse survival. So there is the recognition of these two separate phenotypes. So, and I think obviously, like everything else in real life, there are lots of patients in the middle, or somewhere along the spectrum. So what I think is a fair statement is that ruxolitinib and fedratinib are better drugs for proliferative patients, whereas momelotinib and pacritinib are better drugs for cytopenic or myelodepletive phenotypes. So that is just a broad categorization. I'm by no means saying that these are watertight. They are just a general, pointers, the general pointers. But in second line, to come back to your original question, in second line, assuming they've had ruxolitinib to begin with, I think if they are still exhibiting proliferative features, I like fedratinib. And if they are cytopenic, I would go with momelotinib or pacritinib. Personally, I feel momelotinib is a better drug for anemia. And as long as the platelets are not super low, I would probably favor momelotinib. But if the platelets are very low, certainly less than 25, or even if they're less than 50, I may lean towards pacritinib just because they have more data in that space.
So we'll get to a little more nuance on those, but thank you for telling us how you go through this in your mind, the algorithm for second line. Uh, Now, the thing is that, as you said, most patients, at least historically, have had ruxolitinib. How does it do as a frontline therapy in your mind? And then we'll get into what to do if and when it's failing.
Yeah, I think ruxolitinib is a great drug. I think it's a fantastic, if you think back, I think it's a transformative drug in this field because it was the first, right? It was the first, and patients had nothing before that. And it has absolutely transformed the lives of patients. However, it has some limitations, as the slide here, states. The median duration that patients can stay on it is about 3 years. And after that point, people, about half the patients by definition are off at that point, and that percentage increases over time. Now, why do people come off? A lot of it is due to cytopenias. A lot of ruxolitinib discontinuation is because of cytopenias. And then also with time, it loses efficacy in the sense that people may have a growing spleen, worsening symptoms, increasing white counts, increasing blasts. So all those things can happen. So I think it's a great drug, but it is certainly not a home run. It may not really be anti-clonal. I alluded to this earlier. It has a survival benefit, but that might be indirect because of its anti-inflammatory, anti-cytokine actions. The cytopenias are a problem with this drug because ruxolitinib, an important point to make is it is a very dose-dependent drug. So if you cannot dose it well, you are not really going to get the bang for your buck, so to speak, that much. So, and the dosing is precluded sometimes or oftentimes by cytopenias. And that is where some of the newer drugs might come in.
So, what is the minimal dose of ruxolitinib you would think is worth pursuing, below which it's best to look for alternatives?
Yeah, so certainly nothing below 10 BID. I would not want to have a patient on less than 10 BID. But again, is 10 BID ideal? No. I mean, it's probably 15 or 20 BID that's ideal. In fact, just to put an objective flavor on this, there is now a model called the RR6 model that got published in Blood Advances 2 years ago, in which they looked for factors that predict an inferior outcome after six months of ruxolitinib. And one of those factors was being on a dose less than 20 BID. So that is, some objective evidence to answer your question that lower doses, even less than 20 BID, which is a high dose, in that study, was linked to adverse survival.
The one question I had was you talked about cytopenias being one reason to discontinue, and you said that they could be due to the drug itself. How do you know whether the cytopenia is due to the drug or due to disease progression?
You don't know. And that's always a tough one, no question. But I think sometimes, it's clearly treatment emergent, and or in the other scenario, there could be other signs of disease progression, like spleen symptoms, white count going up, etc., blasts. But clearly, you don't always know. Absolutely, you don't always know. But we know the kinetics that when you start Rux, in the first 12 to 24 weeks, you're going to get low platelets and low hemoglobin. Now, usually for all these years, since we had nothing else, we've kind of fought through that, supported the counts with whatever we could, like danazol, like EPO, these days luspatercept. Those things can be done to try and combat the anemia, for example. But and that's the early cytopenia from ruxolitinib, which I would say is easier to tell that it is from the drug. But later in the disease course, as you rightly point out, it could be difficult to tell whether it's from the drug or from the disease progression.
So without going into the minutiae here, what defines ruxolitinib failure for you, just broadly?
Yeah, like this, I think the message of this slide is that there is not agreement, right? So these are different trials, as have been nicely listed. Recent trials. The first one has been discontinued, but the rest are all relevant. And it shows you that everyone's defined ruxolitinib failure or suboptimal response a little bit differently. So I think in spirit, failure is failure in the sense that it's not helping the patient at all, whereas suboptimal response is it's helping in some aspects, but not in all. Or it's doing something, but not as well as you would have expected it to do. So again, as our viewers can see, this has been defined in many ways in the different trials. Personally, I will point you to the Jakarta 2. As you can see, that's the second row there, as well as the PAC 203, which is the fourth row. These are really the same. These are really the same, and these are trials that have been, completed and published. And I think these are fairly stringent definitions of ruxolitinib failure. But again, the larger point is that this is not uniformly agreed upon. And as people try to compare results across trials, this is very, very important to keep in mind that the populations are not the same.
And is there any greater reliance on other criteria like the Delphi modified consensus?
Yeah, so this is something that John Mascarenhas had published last year, and certainly it's helpful. But uh, I think when you start to look at exact things like is it 20%, is it 30%, stuff like that, that's where there's no agreement. I think it comes down somewhat to opinion. Obviously, this is certainly something that is widely cited and certainly makes a lot of sense. But as you may have noted, it's a little different from what we just talked about in the context of Jakarta 2 and PAC 203. So again, the overall concept is that you're either not getting enough of a spleen response or you got it and then lost it. Similarly with symptoms, but it's hard to nail it down to exact numbers.
So I think you started talking a little bit about this at the beginning about how you think through the proliferative and the cytopenic types of myelofibrosis, which informs often your choice of treatment. Is there anything that you would say you define based on primary refractoriness, suboptimal response, or a progression after initial response as a differentiator in choice of therapy?
Well, one example, that I like to give, it's a fairly simplistic one, but for example, suboptimal response. One easy scenario is where your ruxolitinib is doing a good job in terms of spleen and symptoms, but it's the anemia that's the problem. Now, there you could add on something like luspatercept or a clinical trial of an investigational anemia agent, and that would be a nice example of a suboptimal response where you're just bringing on another drug in an add-on fashion. And that's what's alluded to in the second row here. Um, you could also have the first row scenario, which is uncommon. Primary refractoriness, I think, is very uncommon, but can happen where you don't get any spleen shrinkage at all, or it's growing. Well, then, I mean, it's not working at all, and you could go to either an alternative JAK inhibitor, and this is where I was saying I like fedratinib for proliferative patients, whereas momelotinib, pacritinib, I would reserve for more cytopenic patients. These days, we have a lot of non-JAK inhibitors, so certainly clinical trials are always an option as well. But the third row, progression after response on JAK inhibitor, is clearly the more common of the two scenarios because primary refractoriness is pretty rare. And that is where, I think you look at the strengths of the different approved drugs, you look at what trials you have, and really you try to take everything together and make a decision because unfortunately we don't have one agent that addresses everything equally well. Although I will say that perhaps the closest we are to that is momelotinib because it gives you spleen, symptom, and anemia responses.
And so, as far as the discontinuation goes of ruxolitinib, I guess that's the one that has been the one to have been considered so far to discontinue in the first place. Are there certain pearls of wisdom that you would have because one knows that there are some quote unquote rebound phenomenon in some patients that have been, um, taken off abruptly?
Yeah, absolutely. So RDS is a real deal. It can be pretty bad. There was, in fact, there was a publication during the height of the COVID pandemic from Professor Barbui and the Italian group that it led to increased mortality if you took them off abruptly, which unfortunately, I guess, sometimes happened if they got admitted for COVID and they were on Rux and that was automatically held. So, you can get this cytokine storm. But even outside of the context of COVID, that was just an FYI, you can get this cytokine storm, especially in people on high doses. And so we definitely never want to, abruptly stop it. So in terms of switching, you're right. Most of the experience is with ruxolitinib, going from Rux to something else. And I think that we have it fairly well figured out. What we don't have figured out is going from one of the others to yet another JAK inhibitor. But from Rux, I think we can say that if you're going from Rux to fedratinib or pacritinib specifically, then I would be very careful. I would overlap the two. I would taper the Rux while maintaining some overlap. And the reason for that being that pacritinib and fedratinib have long half-lives, while Rux has a short half-life. So you don't want to be in a situation where the Rux is out of the system and the others have not kicked in yet, as well as pacritinib and fedratinib do not inhibit JAK1, which may be responsible for some of the symptom benefits of these drugs. So if they don't inhibit JAK1, that could be another reason that an abrupt switch could leave the patient sort of high and dry in terms of symptoms. So overlap and taper. Taper the Rux, overlap. I do usually 5 BID of Rux with the other drug, fedratinib or pacritinib, for a week, and then I stop the Rux. Now, momelotinib is different. That one is a short half-life JAK1, JAK2 inhibitor like Rux. So as far as we know, there is no taper or overlap needed. You can just go to it the next day.
Oh, that's very interesting. So then, obviously, you mentioned the second line agents that and the way you think through them. What are the kind of efficacy anticipations that you have once you do decide to make the switch?
Yeah, a great slide. This is really important data. So Jakarta 2, on the left is the fedratinib trial in the second line after RUX. And you see two sets of efficacy numbers there. And the reason being that the asterisked ones, 30 and 27 for spleen and symptoms respectively, applies to or is pertinent to the reanalysis that was done of this trial applying stringent criteria for RUX failure. So I would believe that more than the 55 and 26, because that was, that did have some inherent flaws in the way the original analysis was conducted. So I would go with the 30 and 27 for spleen and symptom response rates to fedratinib in the second line. Now, I will add that just hot off the press, is a trial called Freedom 2, which is a larger trial in the second line. And just quickly for our viewers, spleen and symptoms were 35% each. So certainly holding up to these numbers, maybe a little bit better. Now, pacritinib, persists to, in the middle of the slide here, the spleen response rate to 200 BID, which is the approved dose of pacritinib, was actually 22%. So just a little correction there. So that was actually 22% and symptoms 32 as shown. But very important to remember that PERSIST-2 was a mixed trial. It was not a second line trial. You had about 40 some percent patients who were second line. The rest were not second line. So that's a mixed trial. Keep that in mind. And then on the right is PAC 203. Now, this one was a true second line because everybody had had prior ruxolitinib. And here, as you can see, the numbers are somewhat disappointing at 9.3 and 7.4 for spleen and symptoms at that approved dose. So the efficacy of pacritinib, just based on what you're looking at here, again, remember that there is that one typo where the spleen should be 22 for PERSIST-2. But if you look at just these numbers, my perception is that it is a weaker drug than fedratinib, in this second line setting, just comparing across trials.
So obviously, a word, as you said, that if you do make this switch to fedratinib and pacritinib, an overlap is needed. And then you mentioned that for momelotinib, that may not be necessary. But what do you expect with the momelotinib switch?
Right. And actually, Ravi, just one important point, if you don't mind quickly swinging back to
Sure.
the previous slide. I think to be fair to pacritinib, it's important for our viewers to note that because of pacritinib's lack of myelosuppression, it was primarily studied in cytopenic patients. So it was studied in a worse population. And so, as I'm sure, Ravi, you appreciate, that makes it harder for pacritinib to maybe give us those same efficacy numbers. So yeah, we can move on to momelotinib.
That's interesting.
Right. So momelotinib, I think this is a very important addition to our arsenal, especially from the anemia standpoint. Now, this slide is only focusing on spleen and symptoms, but as you see, there is a difference, right, between the two trials here that you've nicely shown, Simplified 2 and Momentum. Both are second line. There's no heterogeneity here. Symptoms very similar, right? Spleen, however, is different. Now, Simplified 2 did not have a washout. And if you don't have a washout, what can happen is when you stop RUX and start the next drug, by the time you get your first MRI, you may have lost your baseline. So what I mean by that is you get an MRI as your baseline, and then at some point you stop your RUX. You don't know how much the spleen may grow in between. And so when you get your efficacy MRI at 12 weeks or whatever, you don't know how to interpret it because your baseline may not be a true baseline anymore.
Okay.
So So that issue is there with Simplify 2. I would be more inclined to believe the momentum, which had a 3-week washout, So I think the numbers you're seeing here for spleen and symptoms falls somewhere between fedratinib and pacritinib, right? Somewhere in between the two. Again, I'll qualify that by saying that again, momelotinib, because of its strength with anemia, was also studied more in the somewhat cytopenic subjects. So just keep that in mind. This is what makes it so hard to compare the three drugs because they're all a little bit different in how they were studied. But finally, transfusion independence, as is noted on the right, is really the strength of this drug. That is where this drug comes out really strong.
So then just to wrap up about transfusions and its possible solutions, you've mentioned momelotinib, you've in passing mentioned luspatercept, not mentioned on this slide. So what are your agents that you turn to and for managing anemia? How do you think through it in your own mind?
Right. So it's an on-target effect of ruxolitinib and fedratinib through JAK2 inhibition, as you say right on top of this slide. And the disease also can cause it, right? So you alluded to this earlier. Is it the disease? Is it the drug? That's not always clear. But clearly we know that if it's MF-induced anemia, that is bad. That's a poor prognostic factor. Drug-induced anemia may not be prognostically bad, but it's still a problem for the patient and the physician and the healthcare system. So we do pre-momelotinib, we were routinely adding danazol, adding EPO or darbepoetin, occasionally, rarely in my practice, IMiDs, as you show here, to ruxolitinib. We were doing that. Increasingly, we are doing luspatercept, even though it's not approved yet, but it's obtainable because it's there on the market for MDS and it's NCCN endorsed for MF. So we are doing that. Now, momelotinib obviously is a nice new addition, which sometimes, definitely in a lot of patients, can take care of the issue with a single drug that addresses all three aspects.
And I presume that that is now your favored go-to option for the patient where anemia is prompting the change?
Absolutely. Very well said. If anemia is prompting the change, then yes.
Is there, it may be too early to know, but is there utility to the other options after momelotinib?
We don't know. You're right. We don't know. I mean, the frontline use of momelotinib, I'm sure will pick up. The FDA labeling is line agnostic, and perhaps people will choose it more and more as they get more comfortable with it in anemic patients up front. And maybe then we will get some data. But I think at this point, that's switching to something from momelotinib. I don't think we have any meaningful data to speak of.
And just for a second, to keep momelotinib aside, if you had the other choices, danazol, immunomodulatory drugs, erythropoietin, and luspatercept, which do you go to?
I actually think they're all reasonable options. The only guiding principle is the EPO level. So if the EPO level is low, as you know from MDS, then EPO has a higher chance of working. Less than 125 is what I use. Or if they have a low or minimal or zero transfusion burden, then again, same as MDS, it may work better there. But other than that, I don't know that there is a way to select danazol or luspatercept. I don't use IMiDs much for anemia in this setting.
And just the last question, obviously imetelstat was approved for low-risk MDS recently. There's, I know, a large phase 3 study going on in relapse refractory myelofibrosis, but because it's now available on the market, is that a solution, potential solution for anemia?
So I probably would not say so because just from what I recall from the phase 2 that John Mascarenhas had published in the JCO, I think 2 years ago, is that the real excitement about imetelstat in our space is for its apparent survival benefit in the second line after JAK inhibitor. I don't recall spleen symptoms or anemia as being that striking. So I think the interest in it is really from a from some sort of biological disease modification aspect that may lead to improved survival. So no, in short, I don't think I would use that off-label yet for anemia in this setting.
Well, I really wish to thank you very much for all that insightful pearls of wisdom. Obviously, myelofibrosis is still a somewhat rare disease with a lot of options, and there are only very few people that have the expertise like yourself, the volume of patients that you see at MD Anderson, to be able to dissect this and to bring out the pearls that you brought out for our viewers today. And I hope I can draw on you to come back and talk to us about yet exciting options that are taking place and will lead to more approvals in the future.
Absolutely. Anytime. My pleasure. Thank you, Ravi.
Thank you.